Allison, what about virologic failure, virologic rebound? I'm sure you see it in your practice. What's the cause of it usually, and what do you do about it?
So we see it. I mean, I'd say we're seeing it much less, than we used to be, and this speaks to the potency of the regimens that we have. And so I get nervous when I even see low-level viremia because it's so easy to get to undetectable. If someone keeps being, 150, I start to worry. Are they really taking it, even though nobody's failure if they're less than 200? But that being said, we see it. So in our adolescent clinic, about 20% of our kids have virologic rebound. And I mentioned adolescents because that's who I see. Nationally, we think 12% are suppressed for adolescents, so we have bigger problems. For adults, it's like 25% of those who are living with HIV are suppressed. But I think when we see it, it's oftentimes there's systems issues that have gone on. I have to call those out, whether it's actually getting the drug covered, whether the pharmacy sent out one medicine and not the other medicine, and right, so you're taking part of a regimen, whether you had the funds to get it, the transportation to get where you are. So there are all those things that go into whether or not you were able to take the medicine. And then the reality is it's hard to take your medicine every day. It could be one pill once a day, but it's one pill once a day that you have to take that comes along with the stigma that goes into it when you take it. And so there are real implications for that. And so, which is why I'm so excited about, we'll talk about later, some of the long-lasting or long-acting regimens that we're having that take away some of that. So there's systems issues, there's individual issues, there's more systems issues that tend to impact adherence. But usually it's adherence that's causing it. Now you should look to make sure there are no drug interactions, that now somebody is not all of a sudden taking an antacid, and that's what's, a calcium, some sort of containing agent that's actually absorbing their medicine. That's why,
right, sure.
Or they're taking a new medicine, some other, herbal medication, or something that's impacting it. We should think about those things. But usually in this era, with the regimens we're using, it tends to be some sort of.
And how do you walk through those personal issues and home issues and system issues? How do you address that? So someone, comes in, they're on an initial regimen that has been effective for so many people, and yet their viral load's still 1,000 or 5,000 when it should be less than 20 or 40. How do you walk through that?
Yeah. So I'll say the I is not just me, but it's everybody, right? It's the nurse, it's the MA, it's the outreach specialist. It's really the team that's making sure. Our pharmacist says, hey, it's been 2 months since you got your medicine. What's going on here?
Right, sure.
It's a team approach to figure that out and letting the patient know that it's a safe space. And whatever you tell me, it's the safe space, and we're going to work through it. And when you make people feel comfortable, that they're willing to share, well, you know what? I had to pick between the $10 copay, which may seem like nothing to us, but actually for some people, it's 30% of the money they have for that week, right? So I had to pick between that and my kid's formula or this. Then we can start to have real productive conversation about how to address those barriers.
Mm-hmm. And Colleen, that some of the things that you do in terms of evaluation of someone who, like the clinical evaluation of someone who comes in and they're viremic when you think they should be suppressed, what are the things that you'll do?
I think it just starts with conversation, understanding what's going on, what's preventing them from being able to take the medication. And I think it ranges from the, ever prevalent systems issues, which is kind of the vast majority, to things like stigma, not wanting to, to acknowledge that they need to take this HIV medication. And, in very, very, very rare circumstances, drug interactions and things like that are leading to persistent viremia. So, I think the clinically the question is whether you need to test for resistance or not.
Right, yeah, so, yeah.
And a lot of that comes for me from the conversation with the patient, understanding were they really trying to take their medication or have they just been off? Mm-hmm. If they've just been off, I'm maybe less concerned about resistance versus someone who really does sound like they've been trying to take it, they've been getting it in their body on a somewhat consistent basis, and then I may pursue resistance testing at that point in time.
Yeah, it's obviously a relatively expensive test, but on the other hand, it's even someone who is saying that they're taking it intermittently, it's probably some information that you'd need, depending. Like if they said, I just stopped it. One of the things that I'm impressed with sometimes is that people really feel like they are taking it. They really, and then your pharmacist calls their pharmacy and they've only gotten 3 refills in the last 6 months, and then you talk to them and you know what, it is really hard actually, and I do forget.
It often takes multiple conversations.
Right,
You
yeah,
often
yeah.
don't get there in the first visit. It may be the third or the fourth or the fifth visit where it finally comes out, I'm not really taking this.
that, right,
Yeah.
sure.
It's sometimes good to have, at least I've found it's sometimes good to not have me ask that question, but to have a social worker or one of our nurse practitioners ask
Yeah,
that question,
sure.
because my patients don't want to tell me that they've done something that they know that I'll be a little bit unhappy about. They don't want
Yeah.
to disappoint me. So sometimes if somebody else asks the question in my practice, more likely to get the accurate information.
I do find, we have like a tablet in our clinic, and we try to collect these patient-reported outcomes. And I don't know, Julie, if you could comment if you have any experience of kind of looking at patient-reported data in your life's work, and how that maybe we should be using that more as part of our care. Do you have any thoughts about that?
Yeah, I mean, it's come up a lot in this conversation that it's the social determinants of health that are really driving whether people can take their medications and really driving their health outcomes. And that's not something we really, it's not built into structured
Right,
EHR
right,
data.
right,
It's
right.
not, and patient-reported outcomes, I mean, that's not something that's routinely collected, but it's so relevant. And even the stigma barrier, particularly in places like the South that are the hardest hit, it's really driving the epidemic to some extent. So yeah, it's really important.
Yeah, I found that we have a depression screen, we have an alcohol screen, and we also get kind of a sexual history, and we get a little report. And sometimes even that, like again, this kind of what's it called, like social desirability or something, where I'll ask about, well, how many partners do you have, but when they do it on a computer, they're a little bit more likely to say 5 instead of 1, and not that it's good or bad, whatever, but it helps to know in terms of risk and screening and that sort of thing.